So today we'll start our discussion on metabolic disorders of the liver. When you talk about the metabolic disorders of the liver, the prototypical metabolic disorder is Wilson's disease, which is basically caused by copper excess, causing copper toxicity to multiple organs in the body. Before we delve into the Wilson's disease per se, let's see what functions the copper has. Copper is important in connective tissue modeling, in electron transport chain, in pigment production, neurotransmission, even in free radical scavenging. What you need to know about copper and the daily intake is the daily intake with food is around 2 to 5 milligrams, out of which only 1 milligram is getting absorbed. The rest 15-20% is getting excreted in the stools unchanged. The site of absorption is the proximal small intestine, and duodenum and proximal jejunum plays a major role. Now, the absorption of copper was initially thought to be due to divalent transporter, metal ion transporter 1, which is basically a transporter in iron, zinc, etc. But recent studies have shown it is actually human copper transporter 1 that is the major transporter of copper. Once the copper is getting absorbed from the intestines, it gets bound to albumin and other amino acids, out of which histidine is very important, along with alpha-2 macroglobulin, with which it gets complexed, not covalently, but complexed loosely and goes into the liver. Some of this complex escapes the liver and goes to other tissues, especially the kidney. In the kidney, it is filtered, but completely reabsorbed, and there is no urinary excretion for normal copper. The entire excretion is hepatobiliary, and there is no enterohepatic circulation. Coming to some functions of copper, like I told, it has connective tissue cross-linking by lysyl oxidase, free radical scavenging with copper oxide dismutase, electron transport chain, type 4 electron transport chain cytochrome oxidase, dopaminase for neurotransmission, and tyrosinase for pigment production. These are the major enzymes copper is involved in. And what you need to know is molecular copper is never free because it is highly toxic to the tissues. So metallothioneins in the cells, metallochaperones and glutathione bind the copper and keep it non-toxic. So let us just recap what happens. So the oral intake of the copper is around 2 to 5 milligrams per day. It goes and gets absorbed and transported via plasma, albumin and histidine. When the copper does not get absorbed, you get something called as a Menkes disease, and thus it is a problem with copper deficiency. Once it gets absorbed, it goes into the liver where it is used in protein synthesis, formation of ceruloplasmin, storage in metallothionein and biliary excretion. When the problem is with the ceruloplasmin, formation of holoceruloplasmin, which acts as a ferrooxidase, you get Wilson's disease. And when it does not get excreted in the bile, you also get Wilson's disease. Once the ceruloplasmin is formed, it binds the copper and gives it to all other tissues for its functions. Now let's see what happens when the copper is in the liver. When the copper goes into the liver, it gets absorbed or uptaken to the liver with a CTR1, which is a human copper transporter receptor 1. With the human copper transporter receptor 1, this copper gets attached to metallochaperones. The three of the most important metallochaperones are ATOX1, COX-17 and CCS, out of which what you need to know is about ATOX1 or antioxidant 1 copper chaperone. This antioxidant 1 copper chaperone takes the copper all the way and binds it to upper ceruloplasmin, making it ceruloplasmin. And here is the most important step of Wilson's disease, which is basically the gene product of ATP7B, otherwise known as Wilson's ATPase. This is the enzyme which catalyzes the introduction of copper into apoceruloplasmin, making it ceruloplasmin or holoceruloplasmin. And it is the problem with this specific gene product or protein that causes Wilson's disease. This protein also has one more function, which is basically taking the copper all the way into the biliary canaliculus and excreting the copper. So if ATP7B gene does not function properly, you do not get ATP7B gene product, which is Wilson's ATPase. Thus, there is no ceruloplasmin and no biliary excretion. That is basically the pathophysiology of Wilson's disease. Before we all thought it is basically secondary to ceruloplasmin deficiency, but it is not actually ceruloplasmin deficiency, but it is a problem with the Wilson's ATPase not being able to convert apoceruloplasmin to holoceruloplasmin. The reason the problem is apoceruloplasmin has a half-life only 1 day, whereas holoceruloplasmin or ceruloplasmin, as we know, has a half-life of 5 to 6 days. Let us see what we know about ceruloplasmin and copper. Ceruloplasmin is an alpha-2 glycoprotein. It binds to 6 molecules of copper. The word 6 is important. And when copper gets incorporated into apoceruloplasmin, holoceruloplasmin or ceruloplasmin is formed. And this is the step added by the Wilson's ATPase. Now, ceruloplasmin is not very specific for Wilson's disease. Well, the levels are so low, yes, it is very specific. But otherwise, it is not very specific. Why? It is a acute phase reactant. So, whenever you have inflammation, whenever you have stress in the body, ceruloplasmin increases. This is the problem in Wilson's acute liver failure, where you can actually have normal ceruloplasmin. It also increases in pregnancy and estrogen excess. The function of ceruloplasmin is a ferrooxidase and it helps in iron metabolism. So, there is a condition called aceruloplasminemia, where ceruloplasmin and apoceruloplasmin is not secreted and you have iron excess. That is the problem. So, let us talk about Wilson's ATPase. This is the enzyme which has got 6 metal binding domains. It has got 6 metal binding domains, 8 transmembrane proteins and a carboxyl end. In the transmembrane protein, you have your ATP binding domain, nucleotide binding domain and actuator domain. It is the ATP binding domain which has a mutation, which is the most common, and the second most common is in the transmembrane. So, this ATP7B is in the chromosome 13 and the product is Wilson's ATPase. It is a membrane bound copper transporting P1 ATPase. It has got 1443 amino acid. Like I said, it has got 6 metal binding domains and 8 transmembrane segments along with a carboxy end. Now, what is the function of this Wilson's ATPase? There are 3 main functions of Wilson's ATPase. One is the sensing of intracellular copper, formation of apoceruloplasmin to holoceruloplasmin and a biliary excretion of copper. The mutation causes retention of copper in the liver, and the major organ which are involved are liver and kidney, because P-type ATPase is most common in liver and the kidney. Like I mentioned before, the T half of apoceruloplasmin is just 1 day, whereas the T half of ceruloplasmin is 5 to 6 days. That is when ceruloplasmin becomes deficient. So, when you talk about mutations in Wilson's disease, there are more than 600 mutations. Most common type of mutations are compound heterozygotes, and the most common mutations are missense mutations. 2 major mutations which we need to remember is H1069Q and R778L. H1069Q is in the west, whereas R778L is in the east. These are the most common mutations in Wilson's disease. However, there are so many other mutations that is coming in, and it's all in the ATP7B gene. Let us talk about toxicity and copper. Copper is an extremely high oxidative substance, and all the injuries are related to that. Apart from the liver, which we know copper gets deposited and causes necrosis and it can cause acute liver failure, it also involves the RBCs and the kidney. RBC, it causes decreases in glutathione and involves all the glycolysis enzymes, including G6PD. It also causes methemoglobinemia because it converts Fe2 plus to Fe3 plus, and also causes injury to kidney. Now, the injury to kidney is of 2 forms. One is the copper damages the kidney as such. Second is heme, which forms after the hemolysis damages the kidney, and this leads to proximal RTA, renal tubular acidosis. Coming to the pathology, histopathology with respect to Wilson's disease, you can get multiple types of histopathological changes. Can start from steatosis, focal necrosis and apoptotic bodies. Along with that, one important finding you get is glycogenated nuclei. This glycogenated nuclei is kind of specific to Wilson's disease and the liver. With respect to fibrosis, it is almost always periportal, and the cirrhosis is macronodular. This is important In hemochromatosis, you have got micronodular cirrhosis, whereas in Wilson's disease, you have got macronodular cirrhosis. And periportal fibrosis is important. The reason why there is periportal fibrosis is the maximum copper exposure happens in the periportal areas. Why is that? Once the copper gets absorbed from the intestines, it takes all the copper via portal circulation to the liver. Thereby, periportal area is the place where maximum amount of damage happens, and thus fibrosis also happens there. This is in contrast to certain vascular disorders where more often the damage is in the centrilobular, near the central vein. In early Wilson's, the histopathology may be normal. Why? Because there is a lot of metallothioneins and metallochaperones which sequester the liver and make it non-toxic. And though these non-toxic copper will not be seen in the regular stains which are rubonic acid and orcine. Once the metallothionein and metallochaperones get saturated, copper moves out into the lysosomes and starts causing oxidative damage. And that is when we start picking up Wilson's disease in histopathology. You get interface hepatitis, which is actually quite specific histopathological finding for autoimmune hepatitis. Therefore, autoimmune hepatitis is actually a mimicker in Wilson's disease. The other thing what you need to remember in case of an exam point of view is something called the tennis racket cristae. This is seen in electron microscopy and is basically seen in mitochondria. In the inner membrane of the mitochondria, you have the cristae, and this cristae becomes quite big in the part. That is what is called a tennis racket cristae. So let's talk about clinical features and Wilson's disease. With respect to clinical features, the three main organ systems which are involved is liver, CNS and blood. So when you talk about liver, what you need to know is Wilson's disease comes in patients who are within 3 to 50 years of age. Why doesn't it occur less than 3 years of age? Is basically because of the stores of metallothionein and metallochaperones in the body which sequester the excess copper. So once they get saturated, which is around at 2 to 3 years of age, the manifestations of Wilson's disease begin. And why after 50 years you don't really suspect Wilson's disease? The reason being, by 50 years you should have at least 1 or 2 manifestations of significant Wilson's disease symptoms. Even though there are reports of people less than 3 years and more than 50 years developing Wilson's disease. Now that is a rarity, but this is the dictum. Now with respect to liver and Wilson's disease, so many manifestations can be there. We can have acute hepatitis, acute liver failure, chronic hepatitis, chronic liver failure, hepatocellular carcinoma, even cholangiocarcinoma. The other liver diseases which Wilson's disease can mimic is non-alcoholic fatty liver disease. So any child with steatosis on ultrasound should be screened for Wilson's disease. Gallbladder stones leading to common bile duct stones causing obstructive jaundice. Evaluate for Wilson's disease. And an interesting mimicker, autoimmune hepatitis. All the characteristics of autoimmune hepatitis can be also seen in Wilson's disease, including ANA positivity, elevated IgGs, ASMA positivity. Even biopsy can have features of autoimmune hepatitis, such as interface hepatitis. Now when you come to acute liver failure and in Wilson's disease, this is unique. Why is it unique, acute liver failure and Wilson's disease? The reason being, almost always fatal, and without transplantation there is no survival. That is the first thing, fatal. Second thing is the AST and ALT levels will almost always be lesser than 2000. Alkaline phosphatase level which almost be normal. Why? Because alkaline phosphatase requires zinc as a cofactor and copper competitively binds for zinc, and alkaline phosphatase is almost always within normal limits or even low for that matter. So that is taken into consideration where you have a value when you divide bilirubin by alkaline phosphatase should be less than 4. This marks a poor prognosis in Wilson's disease ALF. With respect to CNS, you can have majorly 2 type of manifestations. One is a movement disorder with respect to tremors and dystonia. The other one is rigidity, likely similar to Parkinson's. In tremors and dystonia, you have classical ones. One is a wing beating tremor and one is dystonia, a specific facial grimace called rhizus sardonicus, which is seen in Wilson's. With respect to blood, what you need to know is almost always you have Coombs-negative hemolytic anemia. Coombs-negative hemolytic anemia is almost always an accompaniment in acute liver failure. Why? Because once the liver cells gets necrosed, the copper is completely released into the bloodstream where it attacks the blood cells and causes hemolytic anemia. So in acute liver failure in Wilson's, Coombs-negative hemolytic anemia is almost always the case, along with another organ system dysfunction, which is the renal system. Like I told before, direct toxicity and heme toxicity. Other manifestations are there, we'll come to it. So let's see. Hepatic disease, generally within 3 to 50 years of age, less than 3 because of metallothionein and metallochaperones. Any asymptomatic child with hepatomegaly, any asymptomatic child with transaminitis or steatosis, screen for Wilson's disease. You can have acute hepatitis Wilson's disease, but transaminase will be less than 1500 or 2000. Almost all acute hepatitis with respect to viruses, toxins or ischemia, you have astronomically high liver enzymes. But it is only in Wilson's disease acute hepatitis where your enzymes are just about 1500 to 2000. You can have patients with chronic hepatitis and chronic liver disease, can have compensated and decompensated liver disease with hematemesis, ascites and later on encephalopathy. So it's an autoimmune hepatitis mimicker. They can present with fatigue, malaise, arthropathy and rashes, which are classical symptoms of autoimmune hepatitis. You can have increased transaminases, high immunoglobulins, ANA and ASM will be positive. Keep in mind, NAFLD can be a mimicker in Wilson's disease, gallstones and CBD stones and obstructive jaundice can be there, hepatocellular carcinoma and cholangiocarcinoma can be there. The interesting thing is hepatocellular carcinoma in Wilson's disease need not have cirrhosis. The classical teaching is once you have cirrhosis, you get hepatocellular carcinoma. In Wilson's disease, you have hepatocellular carcinoma with or without cirrhosis. Now, ALF with Wilson's disease is unique. It is almost always accompanied with Coombs-negative hemolytic anemia and renal failure. AST/ALT is less than 1500. Almost normal ALP or even low. Total bilirubin by ALP is less than 4. And there is another one, AST by ALT ratio, which is more than 2.2. The funny thing is ceruloplasmin may be normal. The reason being ceruloplasmin is an acute phase reactant. So in acute liver failure, it may go up and you can get a normal ceruloplasmin in Wilson's disease. And one of the conditions is acute liver failure. Patients who have stopped chelation therapy will likely to be present with acute liver failure suddenly. And another important thing in liver cell failure with respect to Wilson's disease is the copper deposition is almost always in the Kupffer cells and not in parenchymal liver disease. Coming to neuro-Wilson's, neurologic generally presents later and presents with movement disorder, tremor or dystonia with a loss of fine motor control. You can have classically wing beating tremor or a facial grimace known as rhizus sardonicus. You can have Parkinsonism, rigidity and mask-like facies mainly because of the deposition of the copper in the basal ganglia. Rarely you can have peripheral neuropathy as well and autonomic features. But the most important features is the fact that the patients have normal intellect. So you have patients who have completely movement disorders but the intelligence are normal. Now this is a patient who came to us with Wilson's disease and a classical neurological manifestation is called wing beating tremor. This is exactly what the patient had. He couldn't control himself. Once he put his hand in this position, he just couldn't stop but shake. The classical wing beating tremor. The other organ system which are involved are neurologic, which is psychiatric, which is very funny. Diagnosis is almost always delayed. You can have phobias, depression, compulsive disorders. There is a patient whom we had who had diagnosed with schizophrenia for almost 5 years. He went around different doctors and he was not getting better. And just as a neurological workup, when they did MRI, they found tectal hypersegmentis and features classical of Wilson disease, and from there we found out Wilson disease. And with just copper chelation therapy, he is doing well. He has been stopped of all schizophrenic medications now. Now coming to the other organ, eye. Eye is always classical with Wilson disease because we all know that there are two major manifestations in eye and Wilson disease. One is the case of fleshed ring and one is sunflower cataract. KF ring is basically a deposition of copper in the Descemet's layer. Initially, it comes in the upper limbus and lower limbus. It is basically due to the flow of the eye fluids that it deposits in the upper limbus and the normal limbus and the inferior limbus. Later on, the whole limbus circumferentially gets involved and you will have a nice ring. Initially, it's very difficult to diagnose case of fleshed rings without a slit lamp, but later on, when you have an advanced liver disease, you can even see it on normal eyes. The problem with KF rings are it can be positive not only in Wilson's but in other cholestatic conditions including PSC, primary sclerosing cholangitis, primary biliary cholangitis and familial cholestatic syndromes. Now, sunflower cataract, even though it is in the middle of the lens, you have normal vision. Like I mentioned before, blood, you have Coombs-Negative hemolytic anemia, and in kidney, you have Fanconi syndrome, which is basically proximal RTA, you can hematuria, even have stones. Now, in India, there is another manifestation with respect to Wilson disease, which is osteomuscular manifestations. Now, this is probably important for the candidates who are planning to write AIIMS and PGI because this is one of the questions they ask. Osteoporosis, osteochondritis dissecans and rhabdomyolysis. So, osteomuscular manifestation is seen in India more than in other places in the world. You can always have cardiomyopathy and cardiac arrhythmias. You have hypoparathyroidism. Endocrine manifestation of Wilson disease, hypoparathyroidism. Not hypothyroidism, not hyperparathyroidism, but hypoparathyroidism. Because of deposition of copper in the pancreas, you can have pancreatitis as well. So, let us just recap the clinical features in Wilson's. Hepatic involvement is in childhood and adolescence. You can have all kinds of diseases in liver, acute liver failure, acute and chronic liver disease, acute hepatitis, asymptomatic hypertranslypidemia, fatty liver, gallstones, malignancies. Concomitant hemolysis invariably seen when patients developing ALF with Wilson disease. Neuropsychiatric manifestations are almost always later in the lifespan, and 40% of those who have neuropsychiatric manifestations have cirrhosis. And thus, if you have neuropsychiatric disorders, you have to screen for Wilson disease. KF rings are almost always bilateral, and you need to know that KF ring is almost 99% to 100% neurological Wilson's, whereas 30 to 50% in hepatic Wilson's. Slit lamp examination is mandatory for diagnosis so that you can demonstrate copper in Descemet's layer, and disappearance of KF ring is possible with chelation, but it takes years. So, just because you have an absent KF ring does not rule out Wilson disease. So, now we come to how to diagnose Wilson disease. Now, diagnosis is not straightforward with respect to Wilson disease. The reason when you have a straightforward diagnosis with respect to Wilson disease, you are almost always invariably late into the presentation, and coming back to a pre-symptomatic state is almost impossible. And it is very difficult to diagnose Wilson disease. That is why we have so many characters. You have serum ceruloplasmin, 24 hours urinary copper assay, KF ring, Coombs-Negative hemolytic anemia, liver biopsy, even MRI of the brain have shown promise in diagnosing liver Wilson disease, family history, genetic study, serum copper and deep end challenge. Out of which important ones are serum ceruloplasmin, obviously, KF rings, Coombs-Negative hemolytic anemia, biopsies, MRI, family history and genetic studies. Serum copper, deep end challenge are gone out of way, and 24 hours urinary copper assay is very important still. Ceruloplasmin, it is a carrier protein from the liver and it is used to measure the Wilson disease. You have mainly two assays, enzymatic assays and immunological assays. Enzymatic assays are the recently developed, they are more specific. However, immunological assays have been there since quite a long time, and immunologic nephelometry is what is being used and is being right now the standard of care. However, the gold standard is enzymatic assays with respect to Wilson disease ceruloplasmin. Normal values range with 20 to 40 milligrams per deciliter. However, we know that in decreased in CLD, malabsorption, nephrotic syndrome, and increased in inflammation, pregnancy, and estrogen excess. When you talk about ceruloplasmin, just because it is less than 20 does not have an indicator of Wilson disease. If it is less than 10, yes, it is highly specific, but anything more than 11 to 20 is dicey, and you need other markers which you need to see for diagnosis of Wilson disease. And even in 20% of heterozygotes who does not have Wilson disease will have low ceruloplasmin, but will be always above 10 but less than 20. 24 hours urinary copper assay. This is a very important test. Urine sample should be copper-free container and test should be started before chelation. The level of more than 100 micrograms per deciliter is diagnostic and more than 40 milligrams is sensitive. So cutoff to less than 40 for asymptomatic patients increases the sensitivity of the test. More than 100 is specific, more than 40 is sensitive. Now these are the two manifestations of Wilson disease. On the left side you have the KF ring and on the right side you have the sunflower cataract. Sunflower cataract does not impede vision. KF ring starts on the upper limbus, lower limbus and later on involves the whole. So it is negative. Where all is it negative? You have an asymptomatic siblings, you will not get it. Patients who are less than 10 years of age, you will not have it. So these are the two places where you have you have a negative case of flexion or you do not have a KF rings. It is almost always hepatic. 50 to 60% of hepatic Wilsons and 95 to 100% of neurological Wilsons. So next is Coombs-Negative hemolytic anemia. Hemolysis and a negative Coombs test in a patient with ALF always has Wilson's disease has to be ruled out. None. So now coming to the next organ system, which is the blood. Coombs-negative hemolytic anemia. Hemolysis in a patient with acute liver failure, you should always rule Wilson's disease. In acute liver failure, hemolysis is always an accompaniment and renal failure is almost there. Now coming to magnetic resonance imaging in the brain and Wilson's disease. You have something called as tactile plate hyperintensities and central pontine myelinolysis like abnormalities. The one important MRI feature of Wilson's disease, which is not asked but is there, is giant panda in the midbrain. Giant panda, the midbrain looks like giant panda's face. Next is an important investigation and is liver biopsy and the liver copper estimation. Even though histopathology is non-specific with glycogenolytic nuclei, steatosis, apoptotic bodies and focal necrosis, liver biopsy is very important because it can be used for staining copper. It should be at least 1 centimeter in length and it is for copper estimation. Normal copper in the liver is just around less than 50 micrograms per gram of grade. In Wilson disease, it's almost always more than 250 micrograms per gram. Now this is there in Schlesinger and Zakim and Boyer textbook of hepatology. However, in Harrison, it says 200 micrograms per gram is enough. Now what happens in early disease and later? In early disease, because it is sequestered, the copper is sequestered by metallothioneins and metallochaperones, you may not get stainable copper at all. So you will miss Wilson disease. And in later stage, Wilson disease, the copper might be deposited completely haphazardly and you will not get a representative sample by liver biopsy. And that is why liver biopsy has its pitfalls with respect to Wilson disease, apart from the fact that the histopathological changes are non-specific. Coming to another one is called D-penicillamine challenge test. It was supposed to be a very important test previously, probably a decade back, but now it is completely gone out of vogue with respect for diagnosis of Wilson disease. What you had to do was you take 500 milligrams of D-penicillamine 2 times and then you do a 24-hour urine copper. If it is more than 1600 micrograms per day, you have Wilson disease. But now it is completely gone out of vogue for diagnosis of Wilson disease. This is used still obviously in the treatment of Wilson disease because any treatment monitoring has to be with D-penicillamine challenge test only. Now there have been serum copper estimation, but serum copper estimation has not been really good because total copper is 90% ceruloplasmin bound and rest is non-ceruloplasmin bound copper. So when you check serum copper, invariably non-ceruloplasmin bound copper also comes up. So you have to check for non-ceruloplasmin bound copper. If it is less than 15 micrograms per deciliter, it is normal. In Wilson's, it's invariably more than 20 micrograms per deciliter. So incorporating all these things together, we have found a way to diagnose Wilson disease, and that is basically called Leipzig criteria or a modified Leipzig score. With modified Leipzig score, we have to diagnose Wilson. Now, the standard of diagnosis, standard of care in Wilson disease is diagnosis with respect to Leipzig score. Now, in Leipzig score, what all we use? We use KF rings. If it is present, you give a score of 2. If it is absent, you give a score of 0. Serum ceruloplasmin. If it is less than 5, you give a score of 3. If it is 6 to 10, you give a score of 2. If it is more than 11, less than 20, it's 1. And if it's more than 20, it's 0. Urinary copper, mind you, it has to be happen in the absence of acute hepatitis. If it is more than 100 micrograms to normal or less than 100 micrograms, it's 0. So 100 micrograms cutoff is a specific one, whereas a 40 is sensitive one. And 40 can be used for diagnosing heterozygotes or siblings of Wilson disease, but not for a proband of Wilson disease. Coombs-Negative hemolytic anemia is next one. If it is present, is 1. If it is absent, is 0. If mutation analysis on both chromosomes are detected, it's 4. On one chromosome detected, it's 1, and no chromosome mutation is 0. Liver biopsy, if it's more than 250 grams, it's 2. Less than 50 grams, it's -1. If it is orcine or rhodamin positive granules in the liver biopsy, you get a score of 1. If you have a neurobehavioral symptom suggestive of Wilson disease, you can put a score of 2, and a typical MRI with a score of 1. If you have family history or sibling death with suspected Wilson disease, your score becomes 2, and if it is not there, the score is 1. So based on that, you add the scores and see. If it is more than 4, you have diagnosed. So in short, in Leipzig score, if you have score of more than 4, you have diagnosis of Wilson disease. And if you have less than 2, you have diagnosis very unlikely. If it is 2 to 3, that is when you do serum copper, and if you want to do, you can do a copper penicillin challenge test, but it is still not in vogue. So if you want to recap, you have to see KF rings, you have to see serum ceruloplasmin, you have to see 24 hours urine copper, you have to see Coombs-Negative hemolytic anemia, mutational analysis, liver biopsy, CNS manifestations, and family history of sibling death. So now let's see how to treat Wilson disease. Coming to treatment of Wilson disease, the first is always the diet. So certain foods are rich in copper and those should be avoided. For example, shellfish, nuts, chocolates, mushrooms, and organ meat. These have to be avoided in patients with Wilson disease. Then coming to the drugs. Drugs, you have chelators, which are penicillamine, trientine, and the new one ammonium tetrathiomolybdate, and then zinc, which is not actually a chelator, it's actually a methylmethionine inducer and a preventer of absorption of copper. What you need to know about all these drugs are, all these drugs have to be taken at least 2 hours prior to meals. And the treatment is lifelong or till liver transplant, which is curative of the disease. Coming to the treatment of Wilson disease. Like I mentioned before, it is D-penicillamine, trientine, zinc, and ammonium tetrathiomolybdate. With respect to D-penicillamine, it inhibits accumulation of copper in the lysozymes. So what happens? The copper gets solubilized and it helps in the urinary excretion of copper. There is no involvement in metallothionein. It doesn't, whether it induces metallothionein like zinc, it does not. Now the problem with penicillamine when you start therapy in Wilson disease is immediate neurological worsening. Why that happens is basically because sudden mobilization, sudden mobilization of free copper. Mobilization of free copper from the CNS, neurological tissues. That is what causes worsening of neurological status with respect to penicillamine. And once the Wilson worsens, not all recover despite whether you stop penicillamine therapy or not. So that is the problem and the risk we have with D-penicillamine therapy. So you start with a low dose and build it up over 2 to 4 weeks. 250 milligrams OD, 250 milligrams BD to 250 milligrams 4 to 5 times a day. Now, D-penicillamine has to be mandatorily taken in empty stomach. So what you need to do, if you are a parent and have a kid of Wilson disease, what we suggest them is wake the child up at 4 a.m. or 5 a.m., give the D-penicillamine and let them go to sleep again. So that ensures 100% bioavailability of D-penicillamine. Coming to D-penicillamine and adverse drug reactions, we have some problems. You have acute drug reactions and chronic drug reactions. With respect to acute drug reactions, you get a certain amount of immune serum sickness-like syndrome, which is basically fever, rash, arthralgia, proteinuria, which is generally 1 to 2 weeks after starting penicillamine. That is why you started slow. Sometimes you can get skin rashes, you can have pemphigus, and classically elastosis perforans serpuginosa with respect to D-penicillamine and ADRs. There are 2 or 3 adverse drug reactions in penicillamine where you have to be very careful, and if that happens, you have to stop penicillamine straight away. One is good pasture syndrome. Second is myasthenia syndromes. And you have SLE-like syndromes. So if these 3 things happen along with nephrotic syndrome, stop D-pen immediately and then use a different chelator completely. Endocrine side effect of D-penicillamine is hypothyroidism, and you have to give pyridoxine along with D-penicillamine because penicillamine invariably causes pyridoxine deficiency 1. Second thing, it is also an immunosuppressant, D-penicillamine. Coming to the next chelator, which is trientine. Trientine, the structure is different with penicillamine, but the mechanism of action is similar to penicillamine. It also solubilizes the copper for urinary excretion. It decreases intestinal excretion of copper. Neurological worsening can be there with trientine, but not as much as there in D-penicillamine. And it is a very good drug because it has got very minimal adverse drug reactions, and iron deficiency anemia and gastritis. These are the 2 main drug reactions which you expect with trientine. That's all. Coming to another important drug, which is zinc, which is probably used in almost all patients with Wilson's disease. It, apart from decreasing absorption of copper, it also induces metallothioneins in enterocytes. It enhances availability of glutathione. So these things make zinc a very attractive agent for treatment of Wilson's disease. Only ADR is gastritis, which is seen quite often. However, it is manageable. Now coming to another one, which is still not in the market, but ammonium tetrathiomolybdate. And this drug is the only drug where you do not have neurological worsening with respect to Wilson's disease. So neurological Wilson, this is touted as a drug of choice. However, it has not been approved and this is still in the works. It's not available yet. So based on Wilson's disease treatment, you have got 4 main drugs, D-pen. Right now, first line. Now this first line is there in multiple societies, AASLD, American Society, European guidelines, even Indian guidelines. D-penicillamine is the first line. However, trientine, because of its side effect profile, is coming up and trying to replace D-penicillamine. So if you look at Harrison's, you find only trientine as the treatment. First line, D-penicillamine is not even there. So in case you have a decompensated severe liver disease or severe disease, you start off with trientine according to Harrison. But still, with respect to our books, Schlesinger, Zakim and multiple guidelines, the first drug of choice is D-penicillamine. So now coming to how to monitor patients with this disease. So monitoring of patients' disease is basically based on urine copper and serum copper. Now basic mechanism of the drugs are zinc decreases absorption, chelators increases excretion. So this is the basis on which we have to monitor patients with Wilson's disease on treatment. So when you give zinc, what happens is the urinary copper is almost the same, just like before pre-treatment. At the initiation of zinc, you have a urinary copper of 100 micrograms to 500 micrograms, depending upon the Wilson's disease per se, urinary copper. Whereas serum copper will be more than 25. So this will be the, when you start zinc, this is what's going to happen with respect to urine and serum, almost the same. There will not be change in urinary copper or serum copper. So it is urinary copper will be in the range of 100 to 500 and serum copper will be more than 25. However, when you look at urine zinc, you will notice that it is more than 2000 micrograms per day. That means your treatment is adequate. That is with respect to zinc. With respect to chelators, T-pen or trientine, what happens is urinary copper suddenly shoots up to more than 500 micrograms per day, whereas serum copper is more than 25 micrograms. This is at the initiation of treatment. After 3 months, when you monitor, what happens? If the patient has a good control and is taking the medicines regularly, especially in the fasting state, you will notice that with zinc, urine copper would have decreased to less than 75 micrograms per day. And serum copper would also have decreased to 10 to 15 micrograms per day, which is basically a normal copper level for a normal person. Also, you can see zinc level in the urine, which is more than 2000 micrograms per day. So, technically, when you give zinc, all you have to do for seeing good compliance is basically just see urine zinc. 24-hour urine zinc will give you more than 2000 micrograms per day and you know has got a good compliance. Whether it is initiation of treatment or after 3 months to see whether compliance is there. After 3 months for chelation, the chelators, the urine copper would have come down to 200 to 500 and serum copper would have normalized to 10 to 15. So you know the chelation is working. What happens if you are suspecting non-compliance or your treatment is inadequate? What happens with respect to urine and zinc? Zinc is very simple, just see urine zinc and if it is less than 2000, you are fine, and serum copper more than 15, that's it, you know it's non-compliant. With respect to chelation, urine copper would have decreased actually, would be less than 200. And for inadequate dose, urine copper would have gone to more than 500, whereas serum free copper is more than 15 micrograms. Over treatment occurs when you just have to see your free copper for both, which is less than 5. Now at this state, I would like to inform that there is something called as a Nazar's prognostic index, which is basically there in Harrison's. All you have to know is this is a prognostic index in Wilson disease, which is used in acute liver failure. In acute liver failure, if your scores are more than 9, you need to get transplant. That is what it means. Now, more important than that is the parameters of Nazar's prognostic index. You have bilirubin, you have prothrombin time, and you have AST, not ALT. Coming to Wilson's disease and pregnancy. Pregnancy is safe in patients with Wilson's disease. If you have an adequate copper control, the chances of your pregnancy are good. Treatment should be continued with the same chelation. Even though penicillamine is known to have problems with respect to birth defects, follow-up of patients who have been on Wilson's disease on penicillamine, we have not found much birth defects. And we per se I've seen many patients who are pregnant who have had 3 or 4 kids, same patient 3 or 4 kids with Wilson's disease without any problems. You also know that Wilson's disease, the siblings also can be affected because it is autosomal recessive. When you have Wilson's disease with autosomal recessive, if heterozygous people may be there, the siblings. However, they do not have any problem and they do not manifest the disease of Wilson's at all. And they can be donors for living donor liver transplant. And another point is liver transplantation is not indicated in patients with isolated neurological Wilson's disease because there is no evidence that post liver transplant patients will improve, even though liver is the main organ which is affected and liver is the organ which has got the maximum amount of ATP7B gene. Liver transplantation will not cure patients with neurological Wilson's. So let us just recap what we know about Wilson's disease. Wilson's disease is basically because of Wilson's ATPase from the ATP7B gene and it is there in 13th chromosome. It is basically the Wilson's it's 1443 amino acids. It has got 6 copper binding domains, Most common mutation is H1069Q in the west and R778L in the east. Classically with macronodular cirrhosis, a mimicker of AIH. In acute liver failure, total bilirubin by alkaline phosphatase is less than 4. In acute liver failure, copper will be in Kupffer cell and not in lysosomes. Ceruloplasmin may be normal in acute liver failure. India has got osteomuscular manifestations, a Leipzig criteria of more than 4 diagnoses Wilson disease. Ceruloplasmin of less than 10 is almost confirmatory. D-penicillamine challenge test as well as D-penicillamine is becoming out of vogue. Pyridoxine almost always has to be given with D-penicillamine. Trientine is slowly becoming the first line for severe disease, and zinc is the first line for mild disease by induction of metallothionein. Thank you.